Hello, welcome all to the session 3 of the Antegrade CTO Academy. In this lecture, I would be summarizing about the various techniques and the various wires that were used that I discussed in the last two sessions about the various technique and a characteristic about the various wires. Uh, so this is how we should approach our this CTO cases. We should take the bilateral injections and we should carefully analyze the proximal stump of the CTO. And this is how the antegrade wire escalation should go from the proximal CTO cap to the this CTO body and should go into the distal lumen. So these are the three various ties: drilling, penetration, and sliding. And sliding should be the first thing that should be tried. We should look for the microchannels. And depending upon the CTO body, we can escalate or de-escalate the wire. If the CTO body is hard, then we can go with the escalation of the wire with the high tip load at 2, 3. And if it is having a calcium and we need a penetration, then of course the concave pro wires can be escalated. And if once we are through the distal cap into the true lumen, we can de-escalate the wire to complete the procedure. The most important thing needs discussion is the JCTO score. In this JCTO score, we can see if the end is tapered and if it is blunt, then we are going to differentiate into like two things that if it is tapered, then entry with any tapered tip or dimple indicates the direction of the true lumen and it is categorized as tapered. So tapered is a good sign and it a bit easier as compared to the blunt because blunt will have a lesser success because we don't get a chance, we don't get a place where the tip of the wire to be negotiated or where we can escalate the wire. So for blunt, we give a score of 1. For calcium, regardless of severity, 1 point is assigned if there is any evidence of calcium in the CTO segment and we give a score. Presence will give a score of 1. And if there is a bend present between the proximal CTO segment and the distal vessel more than 45 degree, then of course it is again a difficult one and its presence of band more than 45 gives a score of 1. If the occlusion length is more than 20 millimeters, then of course it is a bit tougher and a score of 1 is given. And if it is a retry or second attempt after the first failed attempt, then again it will again qualify in a score of 1. And depending upon the score, we can see the JCTO with 0 are usually having a success rate of more than 95%. And if the score is more than 3, then 3 or above, then it is a very difficult CTO. And the score in between are considered intermediate to difficult. So coming on to the case 1, we can see this is of a patient who had this angina for 2 to 3 years, and in March 2021, his CTO was shown in this both LAD and RCA, and RCA was filling retrogradely from the septal collaterals. So it was a double CTO situation, but in LAD we can see there is a bit of a stump. We can see appreciate in the RA caudal view and in this, a routine sliding method was used. We took a routine workhorse, this routine wire for the sliding technique that is fielded XTR was taken over the microcatheter, fine cross microcatheter was taken. And over this, we took a fielder XT wire and it considering it to be a taper tip hydrophilic polymer checkered wire, it went through the microchannels. And after this, the wire was de-escalated to the routine run through wire and the routine PCI was done and this was the good result obtained. So just we can see with the recapitulating our knowledge that the first approach we see if a tapered tip wire, this polymer jacketed wire can be taken to open the CTO with the sliding technique because many times it will just cause the micro channel and we can de-escalate the wire and complete the procedure. So this was the out of DPS, drilling penetration sliding, that was the case that was done with the sliding technique. Now comes the second case. This particular 60-year-old gentleman had an inferior MI for that a primary PCI was done. At that time, it was seen that the patient had a CTO of the LED. So this was the R3 that was open. And we can see from this LED CTO segment is seen. So next time when we took this RC was open at the time of primary PC, and now we have got a good collateral, filling the LED with grade 2 CC collateral and a good vessel, distal vessel can be seen. So analyzing the CTO segment is most important. We could see there is a taper tip, there is no calcification, no bends. Occlusion length is around 20 millimeter. So we are dealing with a CDO score of around 1. So first thing that we did is took a micro catheter fine cross, and over this filter XT wire was tried to negotiate across if there are any micro channels. So that is the first step we often do out of DPS, as was done. But we could see it was not going through the proximal cap. A bit of calcium can be seen in the helicopter view. Then we thought as we can see the tip is buckling and it is not going, it's not making any headway inside. That means we need to we need to escalate the wire. And this is how we took a Gaia 1 followed by the Gaia 2. And with the help of the microcatheter support, we could see this Gaia wire is making some way ahead. Gaia 2, and with the help of retrograde injection, that should always be done. We should see the wire in various views, whether it is going into the distal true lumen or not. So in this particular case, the wire got into the distal true lumen, and that was confirmed by the retrograde injection. And after that, after taking the Gaia 2 wire, microcatheter was crossed through the CDO segment. And after that, the routine workhorse run through wire was taken. That means downgrading or down escalation of the wire should always be done, because these wire are having a high tip load and the tip can be injurious to the distal vessel. And any distal wire perforation is very dangerous and unpredictable course and very difficult to manage. So we have to be very, very cautious and very meticulous in taking out the hard wires which have a higher tip load, which have a longer this radio opaque lens, because the vessel architecture cannot be seen in a good manner. So it is a very good practice to take out this type of wire and down escalate and complete the procedure over a workhorse wire, like run through a shear blue. So this was after putting a test, this was the end result, and we could see a good timid flow was achieved. So many times what to do if the CTO is having a bridging collateral. So this was the CTO of RCA, we can see, and it was again as a part of the strategy of a sliding technique. We took a filtered XTR wire, but this XTR, despite having a tip load of 0.6 and this tapering, it could not go into the true lumen, and we can say probably it is going into the some small bridging collateral. So at this moment, the best strategy is to take a wire with a higher tip load like Gaia 2 or Gaia 3. So this is what was done in this, keeping that wire in that place. We took a Gaia 3 wire, and we can see this was going into the distal true lumen. And this is how such cases we can escalate the tip load, higher tip load wires. And this made its way into the distal RCA. And after this, we can see in various views, it was in the distal lumen. And over this, we just downgraded the wire, did the ballooning. And after that, this desk was implanted and we could see a good result in the RCA. So just starting from the sliding technique, we went to the drilling technique with the higher tip load wire. And coming on to the this case of a stable angina in which the Conquest Pro wire helped. So this is the particular case of LED osteal CTO. We could see there is a stump, and we tried first with, as usual, the sliding wire, the filter XTR wire, but it was not making a headway because there was a lot of calcium we can appreciate in the allocaudal view. So it's a calcified CTO. And as usual, we took the RCA, and the right coronary collateral shows the this distal course of the vessel. It was a longer CTO, a lot of calcium, and we can see the wire, the tip of the wire is buckling back, and this guide is coming back. Though there is no adequate support, there is a lot of calcium, and this tip load of zero 0.6 gram will not help. So in this particular setting, we need to, we can see it's a short segment and we can make use of the high tip load wire. So in this particular case, we took the help of the Conquest Pro wire, and with the help of the contralateral injection from the RCA, we confirmed the position of this wire, whether it was in lumen or not, in two orthogonal views. And it was in the lumen, it was pre-dilated with very small balloons. And after that, we just we downgraded this and we completed the procedure. So in this presentation, we discussed all three techniques of drilling, penetration, and sliding. And in the next session, I would be discussing about the microcatheters. So thank you all for patient listening and would be meeting in the next session. Thank you.